Hello, my name is Katerina Vaporidi, and in the next 20 slides I will present some basic principles of mechanical ventilation in patients with COPD. If you want to learn more about it, you can enroll in the courses on mechanical ventilation and COPD which we have developed with my colleagues from Crete and are available on Essex Academy website. We will start with the main pathology of COPD, inflammation and mucus plugs, narrowing the small airways and increasing resistance to flow, and destruction of alveoli leading to emphysema and increased compliance. The result in lung function is decreased driving pressure, expiratory flow limitation, and air trapping. The work of breathing of a patient with acute exacerbation of COPD is like building a pyramid. The increased resistance leads to dynamic hyperinflation, and breathing at high lung volumes is as difficult as getting the stone at the top. Moreover, extra effort is needed to overcome intrinsic PEEP, while the increased dead space increases ventilatory demands. The patient with acute exacerbation of COPD has to face this increased work of breathing with decreased muscle capacity. Dynamic hyperinflation leads to diaphragm flattening, so the length-tension relationship of the diaphragm is impaired. Chronic conditions impairing muscle function are also often present, such as use of steroids, malnutrition, or heart failure. The net result is the development of respiratory failure, as a vicious cycle of increased ventilatory demands caused by the vacuum mismatch and the increased dead space ventilation leads to tachypnea, decreasing expiratory time and further worsening dynamic hyperinflation and thus reducing further diaphragm strength. The heart is also affected, as the increased intrathoracic pressure caused by dynamic hyperinflation increased right ventricular afterload and decreased venous return and cardiac output. Caution is required because the often present dehydration, combined with a decrease in systemic vascular resistance after sedation, may cause significant hypotension during intubation. COPD patient presenting with a silent lung which suggests severe obstruction, inward movement of the lower ribs during expiration caused by diaphragm flattening, weak inspiratory effort indicating fatigue, cyanosis and altered mental status suggesting severe hypoxemia and hypercapnia, or hemodynamic instability is a patient in need of mechanical ventilatory support. Acute exacerbation of COPD with respiratory acidosis is generally considered an indication for mechanical ventilation. The aims of ventilation include relief of dyspnea, avoiding respiratory muscle fatigue, management of gas exchange abnormalities, and importantly, avoiding doing more harm through the ventilation. Non-invasive mechanical ventilation is proven effective for the management of many patients with acute exacerbation of COPD. So, patients with not very severe respiratory acidosis, like a pH above 725, hemodynamically stable, and able to manage their secretion, should be offered a trial of non-invasive ventilation. When setting non-invasive ventilation, we need to provide PEEP to counterbalance intrinsic PEEP and support to help the respiratory muscles with the increased load. We can start with a PEEP of 5 and increase gradually, trying to assure all patients' effort trigger the ventilator. Monitoring the delivered tidal volume and patient's comfort will help us titrate the level of support. To increase the chance of success of non-invasive ventilation, we need to fit the mask properly so that there are no leaks, titrate assist to patient's comfort, and manage hesitation if present with medications such as dexmedetomidine or remifentanil. We need to observe the patient closely, and if no improvement is observed within 2 to 4 hours, escalate to invasive ventilation. For invasively ventilated patients, the initial ventilator settings in a control mode aim to manage dynamic hyperinflation, so both tidal volume and respiratory rate should be kept as low as possible, aiming to manage severe respiratory acidosis but not normalize PCO2, and provide adequate expiratory time to facilitate lung emptying. To assess the severity of obstruction, we look at the shape of expiratory flow, if it looks like a square root, and the presence of expiratory flow at end expiration. We measure resistance after an inspiratory hold and intrinsic PEEP after an expiratory hold that may need to be longer than 3 seconds in some patients with inhomogeneous lungs. To manage dynamic hyperinflation, which you can see present in the panel on the left, we need to decrease tidal volume, respiratory rate, plateau time, and increase flow and expiratory time. The increasing peak pressure that you observe is not a problem because it does not reach the alveoli, as you can see in the inspiratory hold, and will not cause barotrauma. The importance of correcting dynamic hyperinflation is highlighted in the example here, where you can see how a decrease of minute ventilation from 10 to 8 liters per minute, decreasing dynamic hyperinflation and dead space ventilation shifted the metabolic hyperbola downwards, and the resulting PCO2 is lower despite the lower minute ventilation. Setting PEEP in control modes. When patients have an intrinsic PEEP of several centimeters of water, it would be reasonable to assume that they don't need any external PEEP. But studies have shown that application of low levels of PEEP facilitates lung emptying by preventing collapse of the small airways. Thus, low levels of PEEP can be used in such patients. As soon as the patients improve, they should be allowed to breathe in an assisted mode to prevent diaphragm disuse atrophy. When the patient is switched from a controlled to an assisted mode, higher levels of PEEP should be immediately applied to counterbalance the remaining intrinsic PEEP and decrease patient's work of breathing. The level of assist is titrated to provide adequate ventilation and comfort, with caution not to over-assist. You can see in this example here how, with increasing assist, patient effort, indicated by the esophageal pressure at the bottom, progressively decreases. Cycling of delay asynchrony or ineffective efforts can occur with over-assist. Breathing is a challenging task. In COPD patients, mechanics will never normalize completely, and these patients have adapted to increased work of breathing. Respiratory drive can be high, and P01 values of 4 have been associated with successful weaning in such patients. Moreover, early extubation to non-invasive ventilation can facilitate earlier liberation from ventilation. To conclude, mechanical ventilation in COPD is management of dynamic hyperinflation. In control modes, low tidal volume and rate, high expiratory time, and low levels of PEEP to facilitate lung emptying. In assisted modes, higher PEEP to counterbalance intrinsic PEEP and caution not to over-assist. Thank you for your attention.